Yes, doctor.
Okay, so I'm Dr. not actually Sathya, Dr. Sathya Udara, Ward 1 Registrar, Castle Street, Prof. Sanathan Roses Registrar. So I got your message and I got to know that you need some basic knowledge regarding ops and gynecological emergencies and whatever the things that may be relevant for your exam and everything for the future knowledge. So thank you for the kind invitation, and we'll discuss something, right? Okay, we have given, so he has given some topics to me, so I'll discuss some of these topics which that are relevant for the day-to-day life and for the exams well. So first thing is so physiology of gynae patient, right? So basically, females, so yeah, structurally, functionally, so the anatomy is different from creatures, right? So they have well-established reproductive system. But what we have to know is from the beginning of their life, from genetic levels, they have arranged. You can hear me, right, everyone? Hope you can hear me.
Dr. Hena Peter.
Okay, fine. Okay. So physiology, anatomy, and body structure, everything is different, right? So that may be from the birth and from the menarche and during childbirth age, as well as during childbearing, especially antenatal period, interpartum, postpartum periods. Again, the physiology changes, right? Especially during perimenopausal period, postmenopausal period. So the hundreds of thousands of changes are there. So very difficult to talk these everything within couple of hours, but we'll discuss some of them which might help you in future, right? First, assessment. To get a good assessment of a female for a gynecological case, you have to take a good history. First, history, basic thing you have to take. So from the age, what is he doing, from where she is from, married or not, and everything, the last menstruation period, and but past medical history, surgical history, drug history, allergic history, family history. But other than that, there are important things to discuss. What is that? Menstrual history and OBS history. Menstrual history per se, when she attained menarche, and how was the periods, how her periods going on, like that for every monthly the 2 monthly the so during period how she behaves, what about the pain, whether she's during dysmenorrhea, pain during menstruation, menorrhagia, bleeding during menstruation, how was that, how frequently she's going to change pads. What about the volume of the flow? What of the flow during menstruation? How frequently she may change the pads clinica, and how many days that he has to suffer from the pain? Everything is added here, right? Uh, and with all that, the physiology change, and we have to get the maximum, and we have to read and we have to get the maximum to do our best. So we'll discuss something like this, right? So uh, history, examination, management, the investigation. So history part. So for menarche, we discuss how her menstrual cycle acts, and OBS part. So how many children does she has? What is the mode of delivery? When she delivered? So what were the birth complications? Everything you have to know. And importantly, contraceptive history. What is the contraception that you use? Maybe condom, maybe chadilla, maybe IUCD, maybe nothing at all. So everything is important for your future things. For me, if you want to know about your gynae patient, if you want to manage that gynae patient, maybe during emergency, so you have to get a good history first. So menstrual history, OBS history, and contraceptive history very important. This may be ectopic pregnancy. She was on condom, but missed it. That's why she here with the acute abdomen. That's why she's having ectopic pregnancy that you have to suspect. For that, you have to have that ability of taking a good history. Examination, again, very important from head to toe. General examination, whether she's will look ill, well, or how she's doing at the moment, what about the BMI, for example, average build and the gynecology, those are very important things when you come to gynecological things. For example, so if it is a very tall or short lady, so that can be associated with something like Klinefelter syndrome. It can be associated with something like Turner syndrome, which may associate with some gynecological emergencies as well. So that's why you need to have that basic idea. Examination, again, general examination very important, and especially gynae patient, we have to check the abdomen. So whether first we have to inspect. So how is there any scars, then distension? Maybe sometimes she has undergone past 2 sections, and this time she had some problems. We might need to open it up again. But sometimes there may be some small scars which are suggestive of laparoscopic surgery. So she had a history of ovarian torsion in the pulmonary. This time she's again with some kind of surgical emergencies in the pulmonary. So with that, you have to examine the abdomen and inspection. Palpation, especially you have to identify the place. So left side may be okay, but usually you have to consider the tubes, ovaries in gynecological patient. Sometimes, who knows, that may be bowel pathology. This may be urinary pathology. Who knows? Left side abdominal pain, this may be constipation. Left side abdominal pain, this may be a UTI, maybe pyelonephritis, maybe calculi. What about the right side? Right side again is like same, maybe bowel pathology, maybe urinary pathology, but we can't miss appendicitis in that case. So palpation is very important. Why? Tenderness of the right hypochondric, tenderness of the right iliac fossa, lower right abdomen is significant. That may be to ectopic. That may be to a salpingitis, uperitis. Who knows? Maybe leaking ectopic, but appendicitis can be there. So that's why you have to develop your skills on palpation. Percussion and auscultation we are not practicing much in gynecology. And what about the other examination things like vaginal examination? Vaginal examination per se, you can do speculum examination, you can do manual examination from using your both fingers, especially by manual examination. You can feel the uterus from upper side, and you can feel the cervix and the lower part from the lower side. So there are certain things called bimanual examination, which you can identify certain problems. For example, those days, for example, so we have scan machines. That's right. We can diagnose ectopic very quickly. But if you are working at tertiary hospital in later as a sister, whatever the master, whatever the person, your team will have a scan machine, and you can detect those ectopic cases infrequent. You can find ectopic patients very soon, and you can do everything in instance. But the thing is, if you work in a peripheral hospital which you don't have any scan machine, as a leading person, as a team leader, you have to have that skill and knowledge regarding bimanual examination. Why? For example, if it is ectopic pregnancy, you can feel some cervical excitation. So that's how you detect. So those days we don't have scan machines. Even in periphery, sometimes we have to suspect. So she had missed her periods for last 2 months. This time came with acute abdomen. You examine from the abdomen, it's tender, and you do bimanual examination. You keep your hand on the tummy and you insert your both fingers from the lower part, the birth canal. So to feel the cervix and adnexia. So it's very tender. That can be ectopic pregnancy. So they have to have that adequate knowledge regarding examination as well. Those are few things that you will have to know. So physiology we have discussed. So assessment we have discussed. Assessment mean, history, examination, and then investigation part. Gynecological patient, so especially females, unless proven otherwise, they are pregnant. That even you have undergone your patient. So as a trainee, so you are going to be. I actually don't know the main audience. Mainly, I met few sisters and that this master. So basically, as a leader, one day you have to think like this. For example, now that patient come to your ward, maybe 14 years of age with acute abdomen, maybe gynecological emergency. So investigation per se, what we gonna do? First, you in SCG. So even though they tell they are unmarried, we can't trust that. Maybe she is 45 years of age, had undergone LRT as well. Who knows? LRT failure rate is 1 in 200. Every lady who's undergoing LRT, so out of 200, one person can have failure. So they can come with a pregnancy. So now she's admitted with acute abdomen. She has undergone LRT, so don't need to do HCG. No, you can't do like that. You have to do HCG levels, especially again IOCDs. We have seen babies coming with IOCD during deliveries. So that's it's very good. We have seen during FB profiles. No? FB profiles usually use VC with those kind of photos. That's why you have to decide on basic investigation first, whatever the situation, right? So urine SCG, one of the basic investigation that you can do. Other than that, in gynecological emergencies, depending on the situation, you can decide the investigation. Basically, what we are doing usually is urine HCG and full blood count. Why? Usually this associated with bleeding and pain and everything, right? So hemoglobin level, platelet counts very important. But if they are chronically like bleeding, so we need to do INRs as well. Who knows, they have coagulopathy, and especially those things are there with jaundice or something like that. Why don't we do liver enzymes and liver function tests? We have to do like that. But always females are tend to come with low abdominal pain. Why don't we do a UFR and urine culture? If they look septic in emergency, why don't we do blood cultures? Those are the basic investigation that we are doing. So we can do hundreds and thousands investigations, right? And especially if you want to exclude some ectopic pregnancies because you can't see something from your scan, so why don't we practice beta HCG levels? There are other things like tumor markers like CA125, LDH, alpha fetoproteins, beta HCG like things. So there are tumor markers. Sometimes your patient or one of your admission might be an acute abdomen with large cyst with a torsion. So in that particular case, we have to exclude what is this. So in that case, we have to decide what is the best investigation for this patient. For example, biochemical investigation. Then at that time, you have to do a proper assessment and do a proper investigation. Why? Usually we don't have basic investigation at the moment in our hospital setup. Why? Those are expensive. We don't have reagents. With that, you have to decide carefully. Otherwise, they can't afford. For example, CA125 level to exclude any benign or malignant pathology in a female. It costs 9,000, above 9,000. In our hospitals, we don't have much ingredients or chemicals to do those things. So we have to have knowledge is very important, and maybe cost also very important. Then you can decide. Your team can decide what are the best investigation for your patient. Other than investigation per se, those are biochemical investigations. They are that's right. And importantly for prolactin levels, TSH, those things are very important in gynecological patient. Why? They tend to have those kind of abnormalities very frequently. For example, infrequent menstruation usually associated with altered thyroxine levels and prolactin levels. So that's why we have to have that investigation with us. Sometimes with oligomenorrhea, then menopausal patient may need LH, lutein hormone levels, FSH, follicular stimulating hormones levels. So in that case, we have to have that investigations as well. So radiological investigation wise, so initial stage we have to do ultrasound scan, sometimes maybe CT and MRI as well. For certain disease like for certain conditions, we have to have investigation like X-rays, maybe for HSG hydrosulfide. There are certain investigations what we can do, right? So management depends according to the situation. Okay, I think you got a basic idea about physiology and assessment of the gynecological patient. Shall we move to those topics? We can start from ectopic pregnancy. Are you following me? Hope you all follow me, right? If you can answer, that's good.
Yes, doctor.
Okay. So am I too fast? Or you can listen this later, right? Then I can use my time maximally.
Okay.
Okay, thank you. So we'll start from ectopic pregnancy. What is ectopic? If you want to ask any question, just ask, doesn't matter. And if you want to change the frequency or the method I'm doing, just tell me, right? So I'm also a beginner. I'm in I'm here in between an on call. I'm weekend on call person to the Castle Street Ward 1 today. In between I have to do this. If I get any calls, I'll be going and come. So we'll try to finish this as soon as possible with a good outcome. Then you can refer this later, right? Ectopic pregnancy. So ectopic means the presence of pregnancy outside of the uterus. So a female newly married, maybe 2 months back, she got married and she missed her periods for last couple of months. So she came with an acute abdominal pain, and first investigation, so admission officer, whatever the person, they have done a urine STG, it is positive. So she looks septic, she's in pain, and she complains of PV bleeding and maybe amenorrhea. So sometimes ectopic people, they come with PV bleeding, with tubal abortion. Sometimes they present amenorrhea. So 2 weeks missed missed periods, and 2 months, and tenderness and nausea, vomiting, and everything. So if it is ruptured ectopic with right hypochondric pain and shoulder deep pain, and everything should be there. The patient looks like Paul Canal, looks like pale, and BP like 80 by 40, pulse like 120, basically like a shock patient. So you need to talk about shock as well, ectopic pregnancy, right? So usually ovary and sperm get connected during on a tube, right? And it come and lodge in the uterus. Whatever the place, they become the fetus, right? Sometimes those what called morulas, the blastocysts or whatever the thing, it stuck in the tube. So there may be a risk factor. So your patient might have a risk factor. What? She's had a history of PID, pulmonary inflammatory disease, which can affect the tube. She had a history of hydrocephalus. One of the tube got affected due to something. But sometimes some people have some problems in the tube, the anatomy and maybe the movements. Like there are certain somewhat villi and parchment, so which move the ovary and the sperm, that yuktano, to the side of uterus. What happened during that situation is that affected, right? So what happened is got stuck. There's another risk factor called history of ectopic pregnancy. So if your patients had a history of ectopic pregnancy, there's another chance. So ectopic pregnancy patients, you can have another ectopic in a 20% of chance. So you had ectopic pregnancy, there's a chance of ectopic pregnancy again is 20%, not like a normal patient who had a normal vaginal delivery previously. So you have to have that suspicion in you. Okay, this may be her second pregnancy with history of ectopic pregnancy. He has undergone self-injectomy or self-injection. We will discuss management later. Okay, now she presented to you with those risk factors, HCG positive. What we have done is we have done a scan, so it's negative. You can't see IUP, no IUPC, no intrauterine pregnancy seen, but you can see there's adnexia cyst. There's a right cyst, like mass, like a fetus with a heartbeat or not. You can see that. So this may be ectopic pregnancy. Sometimes this is a ruptured thing. You can see frequently in the scan. So with that, you have to manage the patient. So ectopic means outside the uterus, but it can be either tubal ectopic pregnancy, it can be ovarian ectopic pregnancy, it can be a cervical, maybe history of if she had undergone past 2 sections, this can be a scar ectopic. Who knows? Sometimes that Yuktan will go and deposit over the scar site, section site, maybe very difficult to manage. This may be abdominal ectopic pregnancy. Sometimes that ovarian sperm that called Yuktan will go deposit in the peritoneum as well. So it's very difficult to manage sometimes. So other the presentation it's very difficult to manage. That's why you need to have a good team around you with good clinical suspicion and proper management plan. Okay. So if you don't see a ectopic, if you don't see a IUP, uterine pregnancy, so what we have to think is this is pregnancy of unknown location. HCG positive, you don't see IUP at the moment, no intrauterine pregnancy at all. What you have to do is you have to do basic investigation, what we call beta SCG, serum beta SCG. Usually in pregnancy, it's positive, right? Maybe value 700,000, 2,000, 20,000, like that. It's rising, right? In early pregnancy, if it is less than 5 plus 3 weeks, you can't see you can see IUP. So your patient came with abdominal pain, SG positive, she's maybe 5 plus 1 days. Who knows? You can't see IUP at that moment. You can't say this is exactly this is ectopic. This is pregnancy of unknown location. You have to give your time, right? What you can do is you can do a BTHG level. It is 1500 or less than that. Again, to see a IUP in your scan, in your radiological scan, you have to have at least 1500 BTHG value. Your first BTHG value is 700. Actually, you might not see that pregnancy. That's maybe. So what you have to do is you have to repeat the BTHG after 48 hours. That's a double in time, right? We are expecting 66% rise in normal pregnancy. Then maybe 5 plus 3 weeks of gestation. You can't see your baby yet. But after 48 hours, BTHG is 3000. Yeah. Now you do a scan, you can see a tiny sac. So you're happy. So that is there. Now you have done your repeat BTHG after 48 hours. Initial one was 1400. Again, looks like 1500 or maybe 1300, like static. So you have to have that clinical suspense. It's not like 66% rise, but still there's a small rise. Like, is this a failing pregnancy or is this a ectopic pregnancy we are dealing with? So every 48 hours, we have to do that. So if you see ectopic pregnancy, maybe right side or left side, whatever the position. So tubal ectopic management is different. Other ectopics are we have to manage differently. But basically what we are talking about tubal ectopics. So there are sites interstitium, ampulla, isthmus, fimbriae. There are different parts of the tube. So according to the type of the ectopic we have to manage. So what you can do is either conservative management. Sometimes BTHG initially with 3000, but next one 2000, next one 1000. Those are called failing ectopic. We can sometimes manage just manage conservatively. And other than that, what we can do is medical management. There are certain medications called methotrexate. Those are cytotoxic drugs. You have to give that if you want to preserve the tube. For example, if she had a ectopic pregnancy in the last pregnancy, so she lost her right side tube. Now again, she got an ectopic pregnancy on her left tube. So are you going to go and remove the tube? Yes, you have to remove. If he says if he's bad, you have to do it. That's a different thing. But you can preserve it if you can do self-in. I will tell there's another surgical method. If you can do medical management or conservative management, sometimes you can preserve. So you have to think about that. Methotrexate is the drug of choice in that case, right? It's certain side effects which might need some observations in the blood count, liver functions. We have to assess, but that is different. We have to give according to the body weight. You can assess BTHG after 4 to 7 days, 4 days and 7 days, and you have to check whether it's going down or not. So according to that, you can manage the patient. Surgical thing is either laparoscopy or laparotomy. We can either remove self-injectomy, either remove self-injectomy. You have to remove the whole part. Self-injostomy means you just remove the baby. You can just cut the cut and open and resuture it again. So that's how you manage ectopic pregnancy. Right. This is the first one. I think I let you to ask question on the different part of funds. I finished everything. If you need any questions, you can just write down and you can just ask at the end of the session, or you can disturb me at any time. Okay, we'll go for the next one. What is the next part? Ectopic pregnancy and CA genitalia. Okay, cancers among genital tract is very sad, very cumbersome situation, right? So from where to where? Okay, you can have vaginal, you can have vulval cancers, you can have cervical cancers, you can have cancers, who knows, tubal cancers. Very rarely, yes, maybe ovarian cancers. So nowadays we are mainly dealing with endometrial, ovarian, and cervical cancers. So pathophysiology, I think you want to know something about pathophysiology as well. So in our body, there are mechanisms that defends our body, right? Usually our body is tend to make tumors. Again, cell heavy, there are cell cycles. There are cell cycles in each cycle. So cell replication is there. So what cells are doing is there are certain checkpoints they are replicating, but they're checking DNAs and everything. There are certain checkpoints, otherwise the abdominal cells they're not going to develop, right? There are certain mechanisms, but we are calling anti what called tumor suppressors. For example, there are something called tumor suppressor genes, but they're active in our bodies. They always try to minimize the tumor formation. There are certain diseases. For example, we'll get a cervical cancer. So human papilloma virus is one of the agents that can disturb or damage or reduce the action of tumor suppressor gene. So if your tumor suppressor gene in the cervix is fails, what happens? Your cervix will make tumors. Simply as that, right? So why don't you get it? So then you will get a cervical tumor. Like that. So endometrial or whatever the certain tumors we can have like that. So that is the basic pathophysiology behind those things, right? So ovarian CAs, we have seen ovarian CAs in 80s and 90s days of ages of gestations as well as teenagers. There are ovarian malignancies. There are different types. I think we don't need everything. So what we have to think is we have to have that suspicious thing. Usually ovarian CAs not that much symptomatic. The usual percentage is abdominal distension, bloating, nausea, vomiting. Those are the usual complaints. But the thing is, it is usually present maybe after 2, 3, 4, 6 months, right? In endometrial CS, not like that. They will present to you with a PP bleeding. Cervical cancer, they will present with a postcoital bleeding. Postcoital means after intercourse, they will present that with sex. So postcoital bleeding is one of the main comparison cervical CS. So, but in ovarian CS, nothing like that. So usually, even I have some bloating like things. Even I'm having some nausea and vomiting in certain instances. Like females, they don't take into the grant. So especially there are some these factors with history of family history, elderly ladies, and with if they are nulliparous or if they don't have babies, if they are unmarried, so they are prone to high risk. They are prone for cervical so ovarian cancers. So in that sense, we have to have that suspicion as a leading nurse or master in one in your stream one day. So if your patient during ward rounds, if you see those kind of a person, you can ask from your junior team. So whether if she's unmarried or person with abdominal distension, so can this be an ovarian skin? That skills you have to develop. I think that's what I want you to do, and that's I think that's what you want to get from me, right? Okay, right. Ovarian, see, there are different tumors, epithelial tumors. There are certain things, but what we have to do is we have to iron from the history and do some examination again, pelvic assessment and abdominal examination, as I discussed previously, and investigation. The basic investigation: CA-125 levels, PTCG levels, alpha-beta-protein levels, LDH level. Those are the biomarkers. Other than that, we have to do basic investigations as well, and make sure to do ultrasound abdomen. If it is suspicious, there are certain things. There are something classification like outline classification, next classification. They are sending M rules and B rules. M mean malignant like things. B mean benign like things. So there are certain ultrasound features that we can your reach out your consultant can see that. That may be important for your parents or maybe your family people and base. There are certain things we can decide. We can get from your scan, but you can get from your scan and we can apply to your patient to see whether there is a benign or malignant lesion. Okay, then other investigation. So staging very important before do any malignant surgery. Staging is very important, especially in ovarian CS. So metastasis and everything you can be there. So what we have to do is staging. FIBO classification is there. You can do whatever the MRI, CT. So according to the unit, according to the consultant, that may be different. Depend on the availability. I don't know in Sri Lanka, maybe next couple of years, how we going to do those staging is maybe a very questionable, right? According to that, if it is suspicious or something, you have to refer the patient to a gyneco surgeon, maybe Maharagam or whatever they may. Certain tertiary cares they have those facilities. With that, you can manage your patient. So whatever the drug, chemotherapy, radiotherapy, whatever the thing, debulking surgeries, you have to do under supervision, right? Even though those are not gynecological emergencies, we have you want me to discuss that. Okay, endometrial C is one of the important and one of the main complaints, and we have seen this regularly nowadays. Okay, PB bleeding, and maybe especially postmenopausal bleeding, perimenopausal bleeding. Those are the main complaints. Usually, if your patient has regular cycle, sometimes may your patient might come and tell I'm having some PB bleeding here and there. Sometimes they can associate intramenstrual bleeding. Sometimes they have continuous bleeding as well. So again, you take a good history. Ask me the family history. Ask whether she's on any certain certain medication like amoxicillin, like drugs that we use in breast CS and everything that can cause endometrial hyperplasia and sometimes malignancies as well. So family is very, very important. So other correlated malignancies are very important risk factors we have to identify, right? So with that, again, examination, abdomen examination, pelvic examination is very important. You put a speculum and see the os, whether it's active bleeding or not, whether there's profuse bleeding or not. There's sometimes if it is a hyper malignancy, you can see some fragile particles coming from the os. Sometimes there are certain conditions called pyometric presence of pus like things inside of the uterus. Again, that can associate with malignancies as well, especially in elderly, in postmenopausal people, even though it can be normal, but it associates with malignancy as well. So that's why we need to do an assessment, right? So how are you going to diagnose that? Yeah, you have to have that endometrial assessment. What is endometrial assessment? You can do different things. You can do a people test, a very OPD level test. You can just keep the patient in the literal position. You can press the equivalent and you can catch the uterus, cervix, and you can just dilation. If not, you can do without dilation. Even without dilation, you can do that. So endometrial sampling is a simple way is people sampling. It will take maybe 4 to 6 weeks to get the report. We can tell what is exactly this there, right? Another thing is DNC, dilatation and curettage. That is what we usually practice in Butterworth now. So you can send the histology sample for assessment, curettage sample for assessment, and you can diagnose the condition according to the histologic pattern. And importantly, if it is localized thing, like if your scan shows it's a localized mass or dilatation or whatever the thing, you can do direct visualization and biopsy. That is called uh, hysteroscopy. Even though we don't much have every place we don't have hysteroscopy, but that is ideal because if you do hysteroscopy, your gain is much high. You gain like 9 to 95%. But if you are doing a DNC, that will be 50%. Why you don't get even you just scrape and you get the sample. That's what we are doing. In people, again, maybe 10% of gaining is there. Why it's like just doing some cure tests without any guidance, right? So, but if it is endometrial hyperplasia, you can do the people and you can get the sample, you can trace if it, see and see whether this is malignant or not. According to the type of malignancy, or the management will be differ. You can refer again this patient into a gynae oncosurgeon and manage accordingly. So investigation wise, again, basic investigations. If she bled a lot, has bled a lot, you can even do a full blood count and see whether HB how much. Whether if it is pale, you have to transfuse as well. So basic management is very important. Always follow that ABC method. That's very important. Even though I'm not discussed like that. Again, investigation, ultrasound, CT, MRI, and at the end of the day, under the gynae oncosurgeon, we have to do the surgery properly. Sometimes normal surgeons also doing everything like surgery. So cervical surgery, the cervical is very important. Uh, it's not like genetic or something like that. So sexual promiscuity, past history of sexual activities, early onset of sexual activities, multiple partners, promiscuity, everything is there. So maybe the male partner who brings cervical C to wife. Sometimes it's not like that, the vice versa. So we have vaccination protocols as well nowadays. With that, trying to minimize the cervical cancers as well, HPV vaccine is gaining something like that. So it's not like acute thing. So you can gain it during teenage age, but you will end up with cervical C in maybe 40s of age. So what we have to do is that's we have to identify it soon. That's why we have Wilbur monthly with pap smear test, maybe every 5 weeks, 5 years if it's normal. So after 35 weeks, if you want to do, you can do a pap smear test and you can see the cytology of the in cervix. And meantime, you can do you can see from a speculum, if you see any ulceration or wound, you can get the sample and send the biopsy into like endometrial cervical biopsy for histology. It will show evidence of uh, malignancy maybe. There are certain things called intraepithelial neoplasia. Those are benign things initially, but they can transform into malignant condition. That's what we are assessing from pap smear test. But if it is positive, we have to do certain things like colposcopy, like certain investigation, which might be very important. If it is cervical CA, if it not the cervical CA, the initial stage, there are certain surgical techniques we can do to manage the condition, like corn biopsies, legs biopsies, those are there. But at the end of the day, if it is malignant, you have to finish it off. You need proper management plan. Why? You have to do basic investigation, you have to do good imaging, you have to identify staging. Sometimes we see patients within cervical CS, so we can't even put insert the finger to vagina. So vagina and everything is like fragile or fragile cervix with dense adhesions to the vaginal wall. So it's an inoperable tumors sometimes. So that's why we need to have early suspicion. That's why you want to know about those things, and you have to refer your patient soon as possible to a gynecologist or whatever the person who are expert on that. Right. So management according to the staging, maybe debulking, maybe chemotherapy, maybe radiotherapy. That will be decided by gynecologist. That is regarding gynecological part. The number 5 question I couldn't get. So I'll skip that. Number 6 regarding trauma. So gynecology trauma. So that may be different thing. We can't even discuss certain things we have encountered day-to-day life. So trauma, maybe gynecological emergency and trauma is very important things, but mainly the sexual assault and everything is there. So we have seen certain ladies like 12 years of age, assault, sexual assault by one of the relations, so maybe uncle or whatever the person, with vaginal tears with and anal tears. So we have encountered those things. So gynecological emergency, yes, there are certain things like so sexual assault is one of the main thing. And importantly, we have seen like certain like people have done certain things for the females. For example, we have seen some surgical damage like cut and everything. That part of things also there. So that's why trauma is very important. We have to inspect the patient after the consent. What we can do is we have to get the consent and we have to do that. For example, we have seen that yeah, especially. So I just want to tell you. So sometimes I mean, so traumas, right? For example, we have seen certain small kids. For example, um, 8 years of age, maybe 9 years of age, presented with vaginal discharge. So there's no nothing at all. So everything was normal. Maybe what you can see only hymenal tear. So that we can just the only thing that you are seeing is hymenal tear. Sometimes we have to do EUA, examiner anesthesia. Maybe they have insert some toys. We have seen those things. Sometimes they with that sexual assault. Some people they have insert some toys into canal, vaginal canal during those procedures. They are left. They are they can't even, they don't know, even young girls, the small kids, they don't know much, so they can come with trauma. They can come with vaginal discharge. So uh, that is there. The question. Okay, I'll slow down. Okay, I'm a bit fast. That's why. Okay, if anything there, you can ask from me, right? Okay, trauma is like that. Okay, assault is the very important thing. Maybe sometimes road traffic accident, they even come with pelvic traumas, damage to the ovaries, uterus, and pelvic organs. In that case, we have to attend. But it's very unlikely to get uterine ovarian damage without any bowel, liver, spleen injuries. In that sense, we have to manage conservatively until surgeon repairs everything. For example, is after RTA, there may be pelvic trauma. So we have to exclude certain damages to the pelvic organs, especially tubes, ovaries, and tubes, ovaries, and uterus. But who knows? We have to exclude other bowel pathologies, maybe bladder injuries, maybe kidneys, maybe spleen and liver injuries. We have to exclude me. So in that sense, we are a bit reluctant to attain like fast people, right? Okay. The next question. So benign tumors, right? So benign tumors of the ovary. The simple question is benign tumors. So benign tumors, even though they are not like emergencies, they can come like emergency. For example, there are certain, so you can have your patient can have abdominal pain, maybe right side abdominal pain. So that may be ovarian cyst, maybe a simple cyst, maybe a complex cyst, maybe a chocolate cyst. What is chocolate? It's called endometrioma. Endometrioma, so is very disastrous thing. Not disaster actually. One of my friend's wife, she's 23 years of age, she's suffering from endometriosis and with multiple chocolate cysts. Even she can't bear her day-to-day activities. She can't bear her day-to-day activities. There are tumors, yes, benign endometriosis, chocolate cyst. Endometriosis, they can have chocolate cyst. It's called endometrioma as well. So life is so difficult. So management steps depends according to the patient and the age and the availability. So we'll discuss about the endometriosis and benign tumors. So endometriosis is the presence of endometrial tissues away from the endometrial wall. So basically ovaries, maybe they can have endometrial tissues in the nose, endometrial tissue in the rectum, cyclical nasal bleeding, cyclical rectal bleeding, cyclical cough, maybe having endometrial tissues inside your lung. So that may be one of the presenting complaint. Other than that, severe dysmenorrhea is one of the main features in endometriosis. It's very difficult to think. Sometimes you can't even cope up. Certain ladies, they can have endometriotic nodules, they can have ovarian endometriotic cyst called endometrioma. As blood collected inside and can become like chocolate-like material. It's called chocolate cyst. So those are benign conditions. What you can do is you can assess, depend on the size, depend on the severity, depend on the complaint. We can do certain manipulation. For example, you can give certain medication like menstrual suppression treatments. You can give certain medication like DMPA, depoprogesterone acetate. You can give some GnR analogs, like there are sophisticated drugs. We don't need that. I think you don't need to know those kind of things at this level. And maybe surgery, laparoscopy or laparotomy. You have to open or laparotomy per se. You can do that. You have to drain it. You have to drain it with the wall. Otherwise, they will it again recurrence is there. So benign tumor, benign cyst endometrioma can become worse, but better to know. And that's it's not treatable, not curable, but you can manage it conservatively or according to medical or surgical treatment. You can control it, but make sure endometriosis is related to the ovaries, right? If you can remove your ovaries, it will be finished. But thing is, how we can remove ovaries in a 35 years of age lady, 40 41 years of lady? 25 years of lady. So we can't do like that. So they will become surgically menopause by then. So we need HRT then. Again, it's problematic, right? So we have to manage accordingly. We have to refer the patient to the pain management centers. We have to give adequate pain relief, especially menstrual suppression. If you want to suppress your menstruation, what is the best thing you can do? Get pregnant. So endometriosis, if you want to get control, you can get pregnant. But the thing is, with those endometriosis, with those chocolates, is your tubes get kinked. Your tubes and ovaries get blocked. But you can do it. So your ovary cannot pass over towards the uterus to meet that sperm. Right. There are certain cysts again, benign cysts, simple cysts. So unless they are not tortured, they are okay. They are very innocent. Sometimes, depending on the size, they can get torsion, right? Obstructed. So maybe partial, maybe complete. But then you can get an acute abdomen, a severe sharp abdominal pain. Usually, if it is centimeters 5 to 9, 13 size of centimeters, they can have torsion. A very small cyst again is like to get torsion. Large cyst again is unlikely to get torsion. There are certain limits, but according to the patient's pelvis size, according to the size of this tumor, according to whether it is fixed to the uterus or not, so your cyst will act differently. In that case, again, if it is a tumor, it's a cyst, you have to do basic investigation. Like every time you have to do basic investigation, and you have to exclude any malignancies as well, right? So why not CA125, BCG, alpha beta protein, and LDH levels? So accordingly, you can manage either conservatively, surgically. Conservative means you can review her in 3 to 6 weeks of 3 months, maybe 6 months, to see the size. If it is regressing, okay. But usually those simple cysts, especially less than 5 centimeters, they are regressing. If it's a bit large, you have to consider, and according to the symptoms, you have to decide the surgery, and maybe open, maybe laparoscopy, right? Other than that, maybe malignant tumors are there, even though we are not talking about malignant tumors, we are talking about benign tumors. So malignant tumors again, like ovarian malignant tumors, we have to consider. Sometimes there are certain tumors like cysts that actually those are not cysts. Like in your fimbrial end of the uterus, the tubes, the fimbrial end of the last end of the corner end of the tubes, you can have certain thing called fimbrias, which catch ovum from ovary. So those cysts can have those fimbrial ends can have certain cysts like hydrid cysts. They can appear as large cysts. Sometimes your tube get blocked, and it will accumulate certain fluid like um, hydrosalpines. So you can see a cyst like hydrosalpine. Those are looks benign, but they can have certain problems. Again, certain tumors, certain cysts that can be malignant, that can be infected. Who knows? That can be an organized pelvic abscess. So patient may be septic. You have to treat the patient accordingly. You have to open it up. You have to give IV antibiotic. You need microbiology opinion. So manage certain situation. Okay. You follow me now. Then we have done 50 minutes. I need 5 minutes break, right? Hold on.
Okay, doctor.
I'm back. Okay, we'll start. Right. Okay. So again, the next part is PID, pelvic inflammatory disease. So basically, you can guess by that name, pelvic inflammatory disease. Uh, any person can get, if she is sexually active, you can get it from your partner, from maybe the risk factors are there, having multiple partners, early intercourse, multiple blah blah blah. Basic things you don't ne? So PID can come like that. Sometimes like therapeutic abortions, sometimes certain ascending infections. Okay. Sorry, right? Okay, so ascending infection like certain ascending infections, especially chlamydia, gonorrhea, maybe sometimes candida, they can they can cause this condition. Why? They can cause cervicitis, they can cause endometritis, they can cause salpingitis. Then ultimately that infection can spread into the pelvis, cause pelvic inflammatory disease. There are certain things to diagnose, right? Basically, this is a clinical diagnosis. What you can is you can see a septic patient maybe, but sometimes they are all right. Some people may have abnormal investigations. IWBs have high CRPs. Some of them are really like calm, like maybe CRP is normal, WBC normal. Those are people. So those are certain people like PID we are treating with uh, have symptoms like that. So they may have post dyspareunia, they may have postcoital pains and everything they can have, right? So with that basic investigation, like basic investigation with ultrasound scan you can do, but we have to treat in a different way. So there are different regime to treat uh, pelvic inflammatory disease. So things that you can do basically what? So intercourse you have to avoid, or you have to use condoms, and you have to get maximum precautions. Otherwise, yeah. Then the I will why something not inform කරා ඩොක්ටර් සන්තිමාල් තමයි පොඩි සිවුනා ඒ නිසා available මේ ප්‍රශ්න සිරිස ඒ ඔපිනියන් එකක් නැහැ අපි within next 48 hours වල කරනවා ඒක කියලා තියෙනවා ඔච්චර සෙවන් දෙක පේෂන දාන්න නෑ මම කිව්වා එතකොට right. So management like precautions. First, what we have to do is we have to prevent it. We have to use a proper partner, or if you are having a multiple partner, you have to take like condoms like precautions. We have to take like that precautions, right? Other than that, you have medication. There are certain preparation. There are certain guidelines to treat PID. Sometimes we are giving initial IM medications followed by oral medications. For example, Kefrax, Ondoxacycline, Fagil, but we have to keep giving that. There are different regimes that use in different setups, especially depend on the availability and the preference of your ward consultant and the protocol. We need protocols, right? PID like that. So basically what we have, PID, you can have abscess, they can have adhesions, they can have chronic abdominal pains. That is very difficult to treat. So that's why we very important to diagnose it early and treat much as possible, right? Other than Bartholian, right? Bartholian abscess, Bartholian cyst and Bartholian abscess. So it's a benign thing actually. So presenting complaint will be lumpectomy valva. Who knows? Lumpectomy valva, that can be a cystocele, that can be a rectocele, maybe your maybe a uterovaginal prolapse. Who knows? Sometimes maybe a wart, can be a wart that can be a sebaceous cyst. This can be either bath or cyst. There are certain places that you can get bath or abscess, not every place. That's why sometimes we see some people refer to us these patients like looks like Bartholian cyst or abscess, but not actually like that. That can be different thing. So Bartholian cyst, having a cyst is okay unless if it is get infected, right? It can become infective and get abscess, pus formation, and she might have a severe pain. So with that, what we can do is we can start analysis. What we have to do, have drainage it. So incision drainage is usual practice in nowadays for every abscess, but because of the high recurrence chance of both those bath abscess, what we have to do is it's a proper thing called marsupialization. That is the ideal thing what you can do. You can open it up, you can suture the wall with the normal valval area, that wall, right? We'll keep at the open space, then the recurrent chance will reduce. What you can do is you can put some dressing or whatever the things. What you can do is you can give certain antibiotics and analgesics to treat. Especially you have to even though it's like look like normal thing, you have to inform regarding hygienic parts as well. Okay, prevention is very important in this kind of situation. That is about pathology. Other than that, okay. So what was the other question? Hold on, how to see that question. Yeah. Yeah, dysfunctional bleeding, accident to overreach එක මම කතා කරන්නේ නේ, right? Okay. So bleeding from the uterus. So there are certain criteria we can diagnose. So it's called palm point classification. Palm means pregnancy, A means adenomyosis, L means leiomyoma, or fibroid, M means malignancy. So structural things that can cause PB bleeding, that dysfunctional or dysfunctional uterine bleeding, and maybe abdominal uterine bleeding, everything that can associate with that. Other than that, structural and functional, those things are there. Maybe coagulopathy, maybe otherwise unspecific, maybe so there are certain things like I can't remember the all things. Palm point classification, according to that, the bleeding we can categorize. So again, this abdominal uterine bleeding or dysfunctional uterine bleeding can be due to anything, right? Who knows? Maybe palm means first on polyp, right? Polyp. Yeah. Palm, polyp, adenomyosis, fibroid like leiomyoma, malignancies like structural thing. So you do scan, you see a polyp, you see a fibroid, you see adenomatic like uterus, you see a malignancy, you treat accordingly. You see like ovarian thing, you see like unspecific thing, we have to manage accordingly. But usually what we are doing is, if she's bleeding, if it's dysfunctional, functional uterine bleeding or abdominal uterine bleeding, what we are doing is we ask about the last menstrual period, and what we are doing is we are doing CG. Unless prone, otherwise we have to do with CG. So if it is negative, what we can do is we can give some medication which will help your blood to clot. That's called tranexamic acid. Oral tranexamic acid, usually our females in heavy menstrual bleeding, they used to get it. And painkiller like mefenamic acid. Mefenamic acid is an NSAIDs, prostaglandin blocker. That's the pathophysiology of the drug. Prostaglandin blocker. Usually endometrium pain, those menstrual pain arrive from prostaglandins. There are prostaglandins secreted from the endometrial tissues. So if we can block those prostaglandins, that will help to improve her pains. That's why we use NSAID blockers like mefenamic acid is a prostaglandin blocker during menstrual pains. So if you have bleeding, give tranexamic acid. If you have pain, you can give paracetamol, yeah, but mefenamic. Most of the time, females they use those drugs. So if it's look like something like adenomyosis or something like that, if you want to make it suppress, you can start certain medication like norethestone. The dose depend on the consultant and the availability. We can use certain medication and like norethestone to help and bleeding. Sometimes continuous, sometimes it's like cyclical. There are certain preparation which can get outside. For example, we can give those medication according to our plan, sometimes every 21 days, sometimes every 21 days for maybe 3 cycles, sometimes continuously. For example, if he's awaiting for TH, for adenomyosis uterus, we can give northosterone continuously until your surgery done, maybe 1 month, maybe 2 months, like that. But example, if there's any abnormal uterine bleeding, especially in younger age, maybe associated with any if unspecific, sometimes we give OCP as well. Like Jasmine, there are good brand called Jasmine. It's very costly, but we give those things to make regular things and to help her, right? That kind of situation we can use in dysfunctional bleeding. And what we can do is, again, is we can do endometrial assessment, endometrial sampling, as I previously mentioned, hysteroscopy, DNC, and people biopsy. You can manage accordingly. If histology says it's a hyperplasia, nothing to worry at all. But we have to do a repeat sample. Again, maybe 6 weeks, 6 months. If it is again hyperplasia, we have to follow up. Why? If it can lead into endometrial CK, there are certain things, right? Next one is H-mole. H-mole means hybrid mole. Usually, like molar pregnancy. It's called molar pregnancy. Actually, what we are seeing is, if she's newly married or whatever, the person presented to you what, so now you are the nursing officer or whatever, you are the master in the ward. So now she's coming of PB bleeding, and again her missed her periods. Or she has recently had an intercourse. Now she did her HCG was positive. Now HCG positive, PB bleeding, unless for otherwise is pregnancy of unknown location. Now we have done a scan not show a intrauterine pregnancy. It's like cystic like lesions, round, voltic up, that can be a H-mole. Again, there are some female fetal particle as well, but it's like irregular. Hello, I am. You can hear me, right? I got a call because I'm the on-call person. I'm getting calls. You can hear me, right?
Yes, doctor. Yes.
Thank you. Okay, so we'll finish soon, right? Okay, now we are discussing about H modes, hydrated mode. That's called molar pregnancy. It's like abnormal thing, not it's like not actually it is like pregnant thing. So we can't accept a baby from that. There are certain things in HMOLs. Sometimes a partial mole, complete mole, a gestational trophoblastic disease, choriocarcinoma. Those are commonly associated with these HMOL like conditions. Female person with urine HCG positive, abdominal pain, PV bleeding, scan will show certain abdominal appearance. What we have to do is we have to do a histological assessment and genetic assessment. Histology assessment, what we have to do is we have to do a dilatation and evacuation with D and E. Sometimes it's a suction evacuation. Be careful. Your uterus is very fragile at that moment, very soft. So you will rupture if you do it forcefully. What you can do is you can send those to your pathology team and you can assess and you have to manage accordingly. If it's the partial mode, it's different. Complete mode, different. If it's the choriocarcinoma, again different. But they are very sensitive to chemotherapy. That is regarding H mode. And shock. Even though we don't talk about shock in this gynecological patient, basically not cardiogenic, not like neurogenic, but mainly hypovolemic, again very low, hemorrhagic shock. Why? They can have bleeding and everything. Sometimes they bleed like tap, especially in operations, gynecological operations. Hemorrhagic shocks are very frequent nowadays with safe hands, very minimal, with good skills with the anesthetic team and surgical team and staff like nurses and minor staff, everyone is there. So shock, again, inadequate perfusion into a tissue. So what we have to do is we have to minimize it. Prevention is very important. So early identification, for example, after a gynecological surgery, for example, after TAH, that's why we need adequate monitoring. That's how you prevent those things like shocks and deaths in pregnant in maternal wards and gynecological wards. So there are certain charts like news charts. We have to check, monitor A, B, C, and vitals. Very important. There's a news chart. We call it as a color grading. I think you know about that. With that, you can get certain things like alarming, right? Alarming to your staff. So you need to do something like that, right? So after surgery, what are the parameter? Now we are talking about shock index. Shock index is heart rate divided by systolic blood pressure. You can't accept more than one in your patient. Shock index should be less than 0.9. If it is more than one, something is there. Maybe she's having pain. That's why she may has tachycardia. She might have fever. That maybe she's having tachycardia. But who knows? BP 70/40 with heart rate of 130. Shock index is more than one. She might bleed inside. That's why you need to get a good history, assessment, see whether she's pale or not, see whether tummy is tenderness or not, see whether the vagina is bleeding from the vagina. It can be there in, even after TH maybe. So what you have to do, you have to do an urgent scan, and do a urgent full blood count, trace it. Her previous HB is 12, now HB is 5. She bleed inside. So scan shows free. So we need early opening. So shock, you can prevent, you can early identify. Treat from according to the plan. We have to take cultures. We have to no, not cultures, not that shock. We have to give blood. We have to give crystalloid. We have to have adequate IV lines. You have to have a drips on your both arm. You need seniors in like as a senior people. The sister or master should be there definitely. So not like juniors. They must learn. But in critical situation like that, skills hands are very important. So shock early identification, initial stage management, and follow-up. So she may need a reopening, right? She may need TH. If she has undergone an elective section, if she has undergone a myomectomy, so if she be inside, she may need to open it up, maybe close it again. Maybe sometimes some people are getting sub rectus hematomas. So inadequate bleeding arrangement can cause subrectus hematoma. Sometimes they can bleed inside. So we need evacuation of hematomas. But sometimes we are getting irritated with for certain things. For example, sometimes in real situations like that, we tend to take the blood from the deep hand, so we'll encounter a HB of 4, 3 in our patient. So pre-op is 13, post-op HB 3, but it's from deep hand, and again we have to repeat, otherwise we'll end up with wrong decisions. In that sense, we have to do a maximum with a sense, right? So that usually happen in our wards. We have IV cannulas in both hands, so we are pumping blood, and meantime we are taking blood from a cannula. So again, not cannula, the veins. So we are pumping from the reason IV set. So this highlights the chance to get abnormal HB level, so we get wrong decision as well. So we might reopen in that sense if you see some fluid. For example, if we miss something like that. So shock again, treat properly, manage properly with skillful hand. That will be very important to make the patients better, right? So again, those are the basic topics that you want to discuss with me. And there's another request for placenta previa and necreta. So placenta previa is the presence of placental tissue on the cervical place. What I mean, it cross usually. You can't do vaginal normal deliveries in that sense. So placenta meaning presence of placental membranes or placental tissues within 3.5 to 4 centimeters inside or close by the cervix. Sometimes there's a major placenta previa. It completely covers the os. So a minor placenta previa, maybe it's 2 centimeters away from the os. If it is anterior placenta, it is different. Posterior placenta, it is different. Take a good history, do examination. She's high risk of bleed. It's a high risk of PV bleeding. If she get any pains, labor pain, she might bleed, right? So assessment very important, basic nutrition very important, and preserve blood, DT, blood and blood products we have to prefer properly. And importantly, what you have to do is you have to plan the surgery. With posterior placenta previa, you might not cut. So you have to do by section. This one, you might not go through the placenta if it is a posterior placenta previa, but if it's anterior placenta previa, you will cut the placenta first. You will cut uterus first, then you cut the placenta, then you reach to the baby. That is in that time is more than enough to bleed a lot. Why? You will see 200 ml, less than that, above 80, like 200 milliliters of blood pumped to the uterus in term. You see, if it is maybe around 3 to 4 minutes is enough to bleed and die on table, got arrest on the table. So that's why you need good team around you, anesthesia nurses. You need to give your best nursing officer for the placenta previa or an accreta, whatever the surgery, right? So placenta previa, again, you cut it, you open it up, and you take the baby out. Very important thing is how you're going to remove the placenta and tissues. So upper segment, yeah, usually you can remove easily, but lower segment again difficult. You can remove, why not? But lower segment is not like upper segment. Upper segment usually contract very fast. Lower segment not like that. It is very lazy to contract, right? So it will bleed if we missed it. So we need certain sutures. We need some stitching materials and techniques to prevent bleeding from the placenta previa. At the end of the day, if we fail for medical management and surgical management like suturing, we have to fish it off, maybe vessel ligation, and finally maybe TH. So placenta previa is that. It may be not that much harm for the baby, but there's a high risk of getting maternal morbidity and mortality in our settings. And accreta, percreta, increta, there's a certain condition in females. So once that's why we always want our people to go normal vaginal delivery. So you can go ahead with a section. Staffs they usually want a section. So once you have undergone a section, maybe one, maybe two, maybe three. So chance of placenta, so morbid adherent placenta risk is very high. your placenta can go and lodge on the scar and develop over that. It might be okay, all right, but sometimes it pierce the environmentrium, pierce the perimetrium, it pierce the bladder as well. So accreta, increta, percreta. Very difficult situation. You need a very skillful hand to deliver your baby. Yeah, you can deliver your baby, but the removal of the placenta is very important. It's very difficult. If it is percreta, if your bladder is involved, it's very difficult. So sometimes what we are doing is we have to keep a piece of uterus there. You have to do a TH as well. So in that sense, again, history, examination, investigation, management, plan the surgery in a daytime with a morning with good skills, good hands, and we have to do it properly with multiple people with good clinical staff that will help to minimize the death or morbidity in maternal maternal sector. So those are the basic things that you have asked from me during the discussion. So do we have any was too fast? It's too fast. Okay. 911 is too fast. Right. I think I'm bit fast because I have to finish my this work and I have to attend my board rounds as well. So I have new admissions as well. There are certain things I'm getting call from blood bank as well regarding positive antibodies for HB of my 5.3% as well. So we need to talk those things. I have sent a few transfer to NHSL as well. So I have patient in ICU as well. I am awaiting placenta. I've got a case tomorrow. I need to take an SCC team as well. So I'm a bit hurry. I have to finish this. Oh, that's why I'm being fast. Usually I'm fast when talking. So we'll discuss some questions. If anyone have any doubt, you can ask now.
Doctor,
Yeah.
no. Doctor, ovarian torsion can explain.
Okay, ovary torsion, right? Ovary torsion. Again, like simple cyst or whatever the cyst, ovary ovary per se can get torsion, like thing. So it will, so usually ovary, the cyst torsion is different, ovary torsion is different. Ovary usually attached to the uterus and usually ovary attached to the lateral pelvic wall. Ovary will get the blood supply main from lateral pelvic wall. The aorta is the supplier for the ovary. From the medial side, you will get certain branches from uterine artery to the ovary. So if it is get because of anything like tissue plane changes or whatever the thing, it will get kinked or it will get rotated over the stream, right? What happened is the blood supply get arrested. For example, with the partial torsion, sometimes it reversed. But the thing is, with complete torsion, if you total, they can completely have not if you block your capillary and venous system, if you block your capillary as venous system, that is very bad. Why? You will get your blood supply from the artery, but within a vessel sticker, veins and arteries get blocked. It's coming inside, but your supply will not go out. If you inside, it will contain blood. So you will contain blood, it will cause more pain, your drainage is affected, is again you're getting pains. What you can do is, so there are certain techniques, but basically we need surgical method, surgical management. If you suspect torsion, you have to go for the surgical intervention, but sometimes it's very difficult to diagnose. Why? We can't easily find, we need a superb hand to diagnose torsion. Why? We have to have a good suspicion, we have to see the blood flow, we have to assess whether it's high or flow, high or slow. With that, you have to open the patient, right? Sometimes maybe laparoscopically, but basically nowadays we have to do open surgeries. Why? Sometimes we don't have instrument nowadays. Even in this hospital, we have maybe one or two instruments are there. For example, laparoscopy even with busy schedules. So we have to open it up and you have to see what has happened. If it's completely torsion, you have seen the black color ovary. almost necrosis, we have to remove the pad. Otherwise, we have so we can plicate, we can retort, we can retwist it. We can twist it. We have to reposition that. We have to plicate into lateral or whatever the place. But the thing is, it's very difficult and it can cause problems as well. Why? Those and those on those situations, they can gain infection as quickly. Maybe ascending infections, maybe bloodborne infection. So necrotic infarcted tissues will get inflamed, infected, then they can develop into abscess or infections. It's very difficult to treat. You have to open it up again. That's why you need to go for proper surgical intervention. Sometimes you have to undergo oophorectomy, even oophorectomy means removal of the ovary. So we have to like get pedicles, we have to get it out completely. But make sure patient will be go happy home within next 24 hours. So we have seen patient with ovary torsions, twisted ovaries, like cyst ovaries is accidents, but sometimes they go home without any problems. Why? Because always is suspicion. If it is completely okay by maybe 2 hours, 3 hours, maybe one day, we tend to send them home. But if anything we can't control by painkillers, for example, PCM given, not settle, tramadol given, not settle, pethidine given, morphine given, still not, crying and shouting like that, we have to open it up and we have to remove that part. That is how we manage overindulgence. Again, make sure ABC is very important. But one thing I should discuss here, anesthesia part. So those emergencies, we don't have fasting either. Sometimes they come with the last meal within the last 30 minutes of duration. Those acute conditions, we have to go for GA with risky GA in those situations. That's why you have to diagnose it properly. If you suspect overindulgence, if she had a last meal within last 30 minutes, if you really want to do it this much, are you going to wait 4 to 5 hours till complete fasting? That's very tricky decision. As senior people, I think most of the people, I think you are intensive people, you know much, but always very important to have that habit of seeing the patient's side and surgical side and your side as well, because if she got any aspiration during surgery, during intubation, so if she get chemical pneumonitis or whatever the things, her life also get affected. But the thing is that okay to keep her for next couple of hours, maybe 4 to 5 hours like that, and waiting get infarct and become deteriorate? That's again different. So in that sense, anesthesia part is very important. So you might deal with these situations. So as soon as possible, you can go with RSI, rapid sequence induction. You have to do the surgery and you have to decide the mode of analgesia after that, after recovery, with ranitidine, maxone, whatever the things with drips. So please consider that one as well. That's regarding ovarian cystic accident or ovarian or those kind of situation. That is how we manage. Okay, I think you got the answer for the question. Is there anything to ask? I think we
Okay,
have
thank you.
fine. Any questions? If you have any question, you can ask me, or other you can put in your inbox. Um, can I ask question? I made those so those sisters at Castle Street recently at the theater, and I made this master for the phone last couple of days. So actually, you are preparing for exam. Is that so? You
Yes.
can okay. When is the exam and what is your targets and what you want to know Oh, have you got any input on positive things there?
You cover, Doctor, more and more. Actually, thank you very much.
If it is okay, then fine, right? Okay. Okay, then shall we wind up? So if anything you want to know, you can just ask, but I'm also a busy person nowadays. But I try to cover many things, but yeah, I don't much have time to read even with my basic knowledge with the day-to-day practice and everything. Okay, then we have done for 1.5 hours. We'll finish. Thank you very much.
Okay, thank you very much. Actually, thank you very much for Dr.
Okay.
Sathya. On behalf of our association, Sri Lanka Intensive Care Nurses Association, we salute you for sharing knowledge with us. Thank you very much. And good night, all of you. Thank you.
Thank you very much.